So do we want to keep waiting for, oh, there we go. We're letting everybody in.
Perfect. And if I could get screen share slides, it'd be fine. Good to go.
All right, we are going to go ahead and get started for this evening. Hello, everyone, and welcome to the Cordova Community COVID-19 and Vaccination Forum. We ask that all attendees remain on mute until requested otherwise in the question and answer portion of the forum, and also to help reduce noise during the meeting. The purpose of this meeting is to offer the community of Cordova the opportunity to hear the latest information regarding the COVID response on both the state and city levels, and have personal questions asked and answered. The city of Cordova is currently following state guidance and recommendations. We hope this conversation offers a good understanding of where we are as a community and how this response is shaping and where we are headed in the big picture. So tonight we have 3 separate speakers. We have Dr. Ann Zink, the State of Alaska Chief Medical Advisor, Dr. Coleman Cutchins, the DHSS State Testing Lead, and Dr. Hannah Sanders, our local medical advisor. Each speaker will give a brief on COVID-19 and vaccination as it affects them in their field and expertise. After the briefing, there will be a period for questions and answers. Please feel free to post questions in the chat as we move through this conversation. Questions from community members were also solicited in advance of this forum and will be incorporated in the discussion. If you would like to ask a question live, please raise your hand and we will call on you as we are able. We ask that participants ask questions promptly to allow time for all the requests and everyone that is in on the call for the meeting. And with that, I would like to say thank you everyone for your participation this evening, and we will go ahead and start with Dr. Ann Zink.
Hi everyone, it's great to be here again virtually, although I will have to say it was much more fun in person last year and great to meet many of you all. So somehow we're still here and over a year later since I was last down there and about 18 months into this pandemic. But unfortunately, Delta is different, and we continue to learn and be humbled by what is happening across the state and this virus as a whole. So thank you for taking the time. I do have just a quick few slides that the team that Cole and I work with put together, and then we can, happy to take any questions at the end or however you want to do it, Heather. So can you see those okay?
Yes, ma'am.
Okay, sounds good. Looking for that affirmative nod, but it's, thank you. So just wanted to share a couple updates on where we're at with COVID overall. So nationally, I think most people are aware that we've had bumps in this process. We've had these different waves that have taken place across the country, across the world, and across our state. And we are experiencing kind of this 4th larger wave here in the country as a whole. I always caution people with this red line at the end that's coming down. It takes a while for cases to be reported in. So you're always going to see a trend at these national graphs at the end as cases. So we're hoping that we're kind of getting up towards a peak, but we also don't know. We're starting to see the South really exploded, and now it's moving west as well as north across the country. And unfortunately, we are really kind of following a similar trend. We are connected to the lower 48 and connected to the world in so many areas and so many ways. And so when we see a surge in one spot, we tend to see a surge here as well. So you can see that back in last November is when we had our biggest surge right prior to vaccination. We didn't have kind of the same Christmas surge that others had after travel. We saw a little bit, but not nearly the same degree. But unfortunately, we've really seen this kind of bigger Delta surge that we're currently experiencing. It's hard to always tell when you're at the top and when you're going to start to come down the other side, but you can see this has been a fairly steep increase as well, and continue to watch these cases. I also encourage people to take a look at the onset date, not necessarily the report date, because it takes a while for these cases to be reported into the state level. Delta is the big driver, and Delta is what is different now. So what is different is we have vaccines, and they're doing an amazing job at preventing hospitalizations and death in those who choose to take it. But we also, layered on top of that, have a much more transmissible virus that is moving quickly from person to person. And so you can see that the Delta has essentially eliminated most of the other variants. We've been getting a lot of questions about the Mu variant recently. So you can see on the top, that little purple there, that is the Mu variant that we have been tracking since January here in the state of Alaska. And you can see that the Delta is definitely outcompeting that. And then Alpha, or the YK variant, or the UK variant, excuse me, we had cases there in January and pretty much have become non-existent. Delta has by far become the predominant variant across the state overall. So we had, like in this last report, 1 new Alpha, 1 new Mu, and 242 new Delta cases overall. The whole state is uniformed in its color these days. We are all red, and we just have a lot of cases across the state. We did change our case coloring a bit. So instead of the 3 levels which we used prior to the CDC having its kind of levels of coloring, we had to choose something, and that's the reason we went for 3 colors for quite some time. But to better follow CDC guidance and allow communities and businesses to be able to interpret CDC guidance, we went down to the borough and census level, and we also did the same kind of cumulative 100 cases per 100,000 is that kind of red level overall, and we do have 4 colors in general. And you can see we just have one little section of orange on there. We are at just over 500. We have 564 cases per 100,000 right now in the state of Alaska. So about over 5 times the upper level of that red across the state. We've had a 12% increase week over week, and we had 808 new cases today alone. Again, it takes a while to enter all these cases. We've had some backlog, and unfortunately just reaching about that 90,000 mark for total residents who've experienced COVID-19, with just over 2,000 hospitalizations and just over 440 deaths overall. Here's a breakdown in age, and we do see a change in what we're seeing with age overall. So you can see that further out the pandemic, that 20 to 39-year-old age group was the majority of our cases, followed by the 40 to 59 age group. But what has changed here recently is we're seeing less cases in our 60 plus and a big spike up in our 0 to 19. So we're seeing more kids impacted. Again, those less than 12 cannot get vaccinated, and they need to be in person and in school in so many different ways. And so there's a lot of reasons that they're gathering, but we are really seeing a spike up there. And again, we see these spikes in childhood cases in the most where areas are least vaccinated. So both states and counties that are least vaccinated, we see more kids who are being impacted by COVID-19. So we're seeing that in Alaska as well, with that age increasing. Testing, again, our flashlights to be able to see how much we've got. This is becoming more limited, despite the fact we've done, on average, about twice as much testing per capita in the state compared to the rest of the country. We are starting to see more limitations in testing availability and longer turnaround times. Big kudos to you all for lots of work collectively to continue to offer testing. I remember very early on in the pandemic estimating with the government how many tests we might need, and it's like, I don't know, 2 million. If everyone got tested 3 times. Well, now we're over 3 million tests. So it continues to go on, and we continue to see that test percent positivity increase. We're at 8.2% positivity. And we're trying to do a lot to increase the availability, particularly of rapid tests here in the state, so people have that ability to test themselves and know if they're positive quickly. Vaccines continue to be our best tool against this virus in general. So 61.4% of those 12 and above have received at least 1 dose, with just over 55% have received both doses that are kind of recorded within the backtrack system. We have had an increase in August compared to July. It has slowed a bit. We had a 46% increase in August compared to July. It slowed down to about 21% increase. And here is the city of Cordova specifically. So nice job being above the state averages. So congratulations on that. Again, these numbers are somewhat imprecise. They're dependent on where someone tells us that they live. And we know that people aren't static people. They tend to move in all sorts of different ways. But the data that we have shows that the city of Cordova is 69.2% of residents have received at least one dose, with 67.2 being fully vaccinated. So that's the data that we have at the state level. Getting a lot of questions about third dose, as well as booster doses. So those who are immunocompromised, the FDA did change their recommendations. For those who are immunocompromised, should receive 3 doses as part of their series. So again, not a booster dose, but just that immune system needs a little bit more to remember the vaccine. And that's available now. And then booster doses is what's been talked about a lot. Those who are not immunocompromised, but are at least 8 months out. We still are waiting for FDA as well as CDC approval on that. We continue to be stood up and ready to offer vaccines if that becomes available, but that is different than this kind of third dose RNA vaccine overall. So that's why this slide really kind of talks about the fact that currently we don't have authorization from the FDA for that booster dose unless it's a 3-dose series for those who are immunocompromised. The big effort of work right now in the state has been over hospital capacity. So unfortunately, with this surge of cases, we are seeing a surge of people requiring hospitalization. We're seeing younger people be hospitalized. We're about 7 years younger this peak than we had in the last peak. But the big difference that we see is that those who are vaccinated are much older who are requiring hospitalization than those who are unvaccinated. So our July data overall, the average unvaccinated person was 14 years younger than the average vaccinated person in our hospital. And getting some data from the Anchorage hospitals this week, the median age for a vaccinated individual in the Anchorage hospitals was 68 versus the median age for an unvaccinated person in the Anchorage hospitals was 44. So big difference in the age group that we're seeing in those who are vaccinated and unvaccinated. So young, healthy people who are unvaccinated we're seeing in the hospitals versus it tends to be people who are older and comorbidities who are vaccinated that we're tending to see in the hospitals. Not 100%, but in general. Currently, 21% of the patients in an Alaska hospital right now are because of COVID-19. We're just pushing up on that 200 mark currently right now. And you can see that this surge of hospitalizations is greater than the surge that we saw in November. So while the cases aren't necessarily higher, what we are seeing is this surge in hospitalizations. And part of that, again, is because of how quickly Delta is spreading across the state and is resulting in hospitalizations. And I hate to think about what this would look like if we had had Delta without the vaccine. So again, incredibly grateful we have some tools against it, but it still continues to push our hospital systems. Here's another breakdown in age, and again, kind of showing this trend towards younger individuals compared to older individuals. And the difference that each individual Alaskan makes a huge difference. I'm happy to talk about hospital capacity and what we're doing in that space and other questions, but really Alaskans have been the key to this response since day one. It's that individual decision to get vaccinated, to get tested if you're symptomatic, to mask up when you're in indoor spaces, to consider getting tested as you travel. And so thanks for all of your work in that space. These layered prevention mitigation are key. You know, I get asked a lot, how long is this going to keep going? And how much are we going to have to talk about this? You know, we don't ask how long we've got to keep our snow tires on, but when it's snowy and icy out, we put our snow tires on. And when it's pouring rain, we wear a rain jacket, and we're used to bad weather. The difference here is that our mitigation efforts also help to change the weather. So your rain jacket is like your vaccine. It helps to protect you, but while it's pouring COVID, you might want to consider a mask or an umbrella and some boots. And so there still may be some people who get it despite those layers, but we want to layer these mitigation efforts when we have a lot of COVID cases across the state. So layering for your protection, the vaccines, masking, testing, and they don't have to be perfect to work really well. And again, in combination, they work better than any one of these on their own. We do have a speakers bureau, so really appreciate the city of Cordova having us tonight. But maybe your hockey team or your, a wrestling group or whatever wants to have additional questions about COVID-19, feel free to ask the speakers bureau. The chamber received money to kind of help support businesses, and they looked at how they could support businesses the most, and they thought they could support businesses by having more people vaccinated so that COVID was less a threat to their business. So with that money, they have opened up this Give AK a Shot. And every week there's a drawing for $49,000 in cash, as well as a 529 scholarship. So tomorrow is the first drawing. And so feel free to enter each week. Right now it's open to those who have been previously vaccinated. And then each week draws a new person who's newly gotten vaccinated. So the odds get pretty darn good here in the next couple of weeks. So hoping to see more people take advantage of that. So anyway, those are just some slides based on some questions that we received before. And I will turn it back over to you, Heather. Thanks.
Perfect. Thank you, Anne. With that, we are going to move on to the city update from Dr. Hannah Sanders.
Hey everyone, thanks for having me. So currently Cordova has 9 active cases. We had our Delta spike earlier. We had a total of 200 cases over the 2 months when Delta first came to our community. Fortunately, I think that high vaccination rate has helped our community. One question that I get frequently that I'll just touch on here is the question of our alert levels. We are following the state, and as you see when you look at the data that Dr. Zink shared with the national COVID cases and the state COVID cases, we tend to track. COVID is a respiratory illness, and it's such a sneaky illness. Even though we're geographically isolated, we also track right with the state. So that was kind of the reason that we decided to go along with the state's alert levels, as well as the state's providing us a lot of very important epidemiology and other information. As you see, their vaccination rate is a little bit improved from the data that we had previously, so I'm glad to see that 67%. And I'm here to answer any local questions and listen and learn from Dr. Zink and Coleman. Thank you for coming.
All right, thank you, Hannah. We are going to move to Dr. Coleman Cutchins, who is the state testing lead. Coleman?
You know, not much else to add from Dr. Zink's presentation. A couple things I guess I will mention, though, is we've really put out a lot of information on monoclonal antibodies. You know, there's a lot of misinformation and kind of poorly designed information about outpatient treatment and prevention of COVID-19. Really, at this point, the data could change, but at this point, the best evidence and guidance we have are vaccines, are our key prevention tool. You know, those who get breakthrough infection and are high risk, or those who are unvaccinated and high risk, the only drug shown to prevent people's risk for severe disease are this drug class called monoclonal antibodies. So we've actually converted over our state call line, our vaccine call line, to a monoclonal and vaccine call line. So if anybody has questions, I'll put that in chat. Please reach out. Other than that, testing, we are maintaining testing capacity pretty well here in Alaska, but with this current surge in the lower 48, we are seeing supply lines getting strained. I know you guys are doing quite a bit of kind of point of care rapid testing down there. We are doing our best, you know, to maintain those, but just kind of want everyone to understand that, you know, those supply lines are getting strained. There is really good access still to these at-home kits. So for people from the community that need to travel and need a test to travel, specifically outside of Alaska or outside of the U.S., a lot of those at-home kits count. So just kind of keep that in mind as another good, easy option to test. And that's all I really have. You know, happy to answer any questions later.
All right, perfect. Thank you so much, Coleman. With that, we are going to go ahead and go into our question and answer portion of the meeting this evening. Is there anyone online who has a question that they would like to ask in person? If so, please raise your hand and I will unmute you so you can do so. Okay. Sarah Parker. Go ahead and ask your question.
Hey, so we can all agree that vaccines offer significant personal protection, but I'm curious with the current technology that we have, is it possible to eradicate COVID with vaccines as has been done with smallpox? And why or why not?
That's a great question, and I'm happy to take a stab at it, and looking forward to other inputs as well. I think that the big answer is we don't know for a series of different reasons. First of all, having a disease that does have some degree of asymptomatic spread makes it much more challenging to minimize its impact. It doesn't make it impossible. Polio, 95% of the cases are asymptomatic spread. And so we do have other diseases where vaccines have been incredibly efficacious. When we look at things like herd immunity, we're looking at how, in a population as a whole, how well can that population be protected, either from natural infection or from vaccines, and how quickly does it spread from person to person. So when our epidemiologists do this calculation, they look at how quickly it spreads from person to person and how great of protection either the vaccine or natural immunity provides. And so for things like smallpox, it spread quite easily from person to person. And the vaccine did provide amazing protection at preventing disease overall. With the Delta variant, we are seeing this disease spread more quickly from person to person. And in combination with that, we are seeing the vaccine be slightly less efficacious. So it still works amazingly well at preventing hospitalizations and deaths, but it isn't quite as good at preventing all infections. So the combination of those two factors makes that level of people that need to really have really robust protection from the disease higher than it had been previously with the Alpha variant. The other thing that we don't fully know is how well someone who's previously had COVID, they're protected, as well as how long protection lasts from vaccination as well as from natural infection. So when someone gets really sick from the disease, it looks like they have better protection. If it looks like they were recently sick from the disease, they have better protection. And it also looks like immunity starts to wane over time, both with natural immunity as well as from vaccination. And so it's for all of those reasons that I think it's unlikely we're going to get to a point of COVID elimination anytime soon. That being said, we have lots of diseases that are not eliminated, that we do lots of work to try to minimize their impact and minimize the number of deaths that we see every year from them, as well as the impact overall on the community. We get asked often, when will you stop talking about it? When is this all over? And I would love to be done talking about it like last year. That would be awesome in so many different ways. But there are two separate answers to that. One is in the department, our mission is to promote the health and well-being of Alaskans. And COVID right now is a major threat and continues to be a major threat to the health of Alaskans, as we see in our hospitalization and death numbers. I'm happy to talk syphilis, and we're happy to talk tuberculosis and other questions. We don't get asked to a lot of city council meetings to talk about those things, but there are lots of other things that we also need to be talking about the health and well-being of Alaskans. And we sometimes joke that we're not the Department of COVID, we're the Department of Health and Social Services, and I'm not the Chief Medical Officer of COVID, even though some days it does feel along those lines. So from a DHSS and a health perspective, we will always be promoting the health and well-being of Alaskans, whatever that looks like and whatever the challenge may be, COVID and non, if it's eliminated or if it's not. And I think the chance of eliminating this disease is vanishingly rare, if completely unlikely. From a larger state perspective and engaging more state people, the goal has always been the same. And that is to never overwhelm our systems to the point that we have system collapse. And right now, we're on the verge of collapse of two major systems. The first is healthcare, and the second is schools. Kids do much better with in-person learning. And we do our kids justice, as well as to make sure that people can get treatment for COVID, as well as non-COVID related conditions. Everything from a dirt biking accident to appendicitis, to a stroke, to a heart attack. We need to make sure our healthcare systems are intact. And right now, we are increasingly unable to transfer patients, not only within the state of Alaska, but out of Alaska. And it's because of those reasons that the state is more involved with COVID right now, because of the threat to these two major systems that we all universally rely on between educating our children as well as the healthcare. So the goal remains the same in flattening the curve, keeping those cases underneath that hospital capacity. But that hospital capacity has shrunk a degree since COVID first started, as we've seen a lot of people leave the healthcare field. So this was a really long-winded answer to your question. I don't think COVID's going to go away anytime soon. It's going to be here with us for a while. But that doesn't mean that while it's threatening our structures such as school and healthcare, we don't do what we can to help keep those structures in place so we don't have excess deaths from other things or impact in other ways. And we don't continue to promote the health and well-being of Alaskans, be it COVID or non-COVID related issues. I don't know, Dr. Sanders or Hutchins?
I think that was an excellent answer, and I agree with you. It doesn't look like this is going to be going anywhere. However, we do need to keep our healthcare system intact, which is why we're really working to layer every mitigation strategy that we can on, and why vaccination is so important. So thanks.
I kind of really put it into perspective of, other diseases that we had vaccine for that we didn't quite eradicate, but it really doesn't have a burden on our society anymore. I agree with everything was said. I don't know that we're going to, eradicate it like smallpox, but this is a very different virus. But there's other things, like polio, measles and mumps and pertussis that are still around, but it has a very small burden on our society. Very few people get severely ill. So I think really the goal at this point is, get enough people covered via vaccination. And, the people that we have due to natural infection, and really bring that burden down. The number of people who get severely ill and hospitalized is cut way down, because that's really what ultimately, if this virus was mild, like all of this wouldn't have happened.
Okay, moving on to our next question. It says, can you expand on the pediatric hospitalization situation in Alaska? What is the capacity availability within the state for pediatric beds? Are you seeing primarily children with pre-existing conditions, or is it fairly evenly divided across the demographic?
Yeah, so it's a fantastic question. And a slide that I did not have in here, but I find is a very powerful slide, is looking at the number of hospitalizations in the ages 0 to 17 across the country from COVID. And you'll see that we are about twice what we were at the peak in November of last year with the number of children who are being hospitalized from COVID-19. There's a big debate on if that is Delta is actually making kids sicker, or if it's just that more kids are being exposed and it's transmitting and moving so quickly that we're seeing a lot of kids impacted. COVID's definitely not the only thing impacting children right now as well. So particularly in the South, there's a big RSV surge, respiratory syncytial virus, that particularly causes young kids to be quite sick and is often the cause for many hospitalizations in the state of Alaska. And we've also had a pickup in our RSV cases recently and actually issued an epi bulletin about that last week. Our hospital capacity for PEDS beds is challenging because while we have PICU and NICU beds, the most intensive care beds for pediatric intensive care, many physicians like Dr. Sanders and others do an amazing job at helping to stabilize and care for pediatric cases. But depending on what that pediatric type may be, it may be in a pediatric bed, it may not. They may need to transfer them, they may not. And so it really varies, particularly based on the location as well as the disease process and why they need to be transferred. We know in Alaska our capacity in general is limited. We know that our pediatric capacity is even more limited than our adult capacity, and that we oftentimes rely on places like Seattle Children's as a backup. What we're also seeing nationwide is that the pediatric hospital system is being stretched in a way that the adult system was stretched last year, but the pediatric system never was. So many pediatricians and PICU docs are trying to figure this out in real time and figuring out how to support just lots of kids and lots of cases right now. In general, kids do really well. They have very minimal or mild symptoms, but I've seen kids now as young as 13 days with COVID-19, as we've seen quite young kids, and we're learning a lot about it in kids that young, and who we should worry about, who we shouldn't worry about, and try to watch them closely. But we still have a lot to learn, particularly in the pediatric world in this case. We've been fortunate that we have not had any pediatric deaths in the state of Alaska. That's unusual. Most states have, and I continue to knock on a lot of wood and encourage us all to do what we can to protect our kiddos because I worry it's only a matter of time until we do have a pediatric death. And the last time I checked, and Coleman, correct me if you have a different number, was we've had a total of 17 hospitalizations in the pediatric age group. Again, we're counting that as newborn until 18. So small compared to our overall adult numbers, but we're seeing quite a few cases overall. So that is the state and national level on that. I don't know, Dr. Sanders, what would you say from your perspective?
Cordova has started to see RSV as well. And certainly here at our hospital locally, we're able to take care of a certain level of pediatric patient and stabilize them and often treat them for RSV, flu, or even COVID without having to medevac them. One important thing that I will add is RSV is a droplet, which we have known for a long time that masks help prevent spread of those droplet illnesses. A lot of times older kids don't get so sick with RSV that they need hospitalization, but they will transmit to younger children RSV, and so the masks are a very effective tool for those other respiratory illnesses as well.
Perfect. Thank you, ladies. We are going to move on to a question from William Deaton.
Hello. Earlier you mentioned the unvaccinated cases in the hospitals, and I was kind of wondering how many of those people previously had COVID, and are you tracking natural immunity reinfections? Thank you.
Yeah, so great question. I wish I had easier answers to these questions because it's really hard to track some of this. So we have a couple ways to look at previous infection. So if someone has tested positive for COVID-19 here in the state of Alaska, and we have that as a case record, then that's easier to say, okay, this person had previously had it, and then they have now been reinfected. We are working on a reinfection bulletin, looking at who's getting reinfected with COVID-19 in the state of Alaska specifically. There's no perfect marker for infection. So there's no test that I can do to be like, Dr. Sanders had been previously infected by COVID, because your antibodies last for a short period of time and then come down, but there does appear to be some longer protection, both from memory B cells as well as T cells. So for the tracking component of how many people who have previously had it and the impact of natural immunity, it's really hard because, again, people have different variability in their immunity, from very mild protection to really robust protection. And we see that wanes over time as well. So looking forward to that reinfection bulletin. We don't have great data on people who have been previously or who are currently hospitalized on how many of them have been previously infected, but we are currently going through previous numbers to see who had been previously infected. Again, they may have been infected, we just don't know it, but if they're in our case data, then that is helpful. I will state that we've got a couple different pieces of evidence. One, there's an Israeli preprint study that gets quoted a lot, but if you go to the whole bottom paragraph of that article and actually read the whole thing, it talks about the fact that people who had been previously infected and got vaccinated were significantly more protected than just people who had been vaccinated or previously had infection. And so vaccine plus previous infection appear to be more protective than just previous infection alone. That also was replicated in the Kentucky study, where they looked at people who had been previously infected and found that those who'd been previously infected were 2.5 times more likely to get reinfected if they were also not vaccinated. So again, that is part of the reason why we recommend people who have previously had COVID to consider getting vaccinated, because the data we have to date shows that you're less likely to get reinfected if you've been previously infected. But looking forward to some more Alaska-specific data. But others?
I'll put that Kentucky study in chat. I think it's really interesting. I think one thing that is tough to, when we look at natural infection, somebody gets infected, they have immunity from that versus vaccine, what we really see is a more consistent immune response and a more predictable immune response. We don't know all of the ins and outs yet. There's a lot of unknowns with, people that were infected by the virus. Dr. Zink does a really good job at this. There's really no difference, though, the way your immune system responds to the virus or the vaccine. It's the same level of immunity. Your immune system sort of acts in the same way. You just don't have the residual bad effects of the virus. So, there's no difference in terms of the antibodies, the response, from vaccine. It's not less complete, and there is some studies looking out there on that. So I just really encourage people to think about it that way as well.
This is just one other thing to add to Coleman's point there. Getting vaccinated does not take away your natural immune system's response to the virus if it sees it again. And a vaccine basically teaches your body's normal, healthy immune system to be able to respond more quickly to the virus once it sees it. So the fundamental basis of being healthy and well is to support our overall health and well-being. And so that is our mental health, our physical health, our social health, eating well, exercising, making sure our immune systems are well taken care of. And our immune systems are also, taken down with a lot of stress. So taking care of our immune system. And then when we get vaccinated, that just tells our immune system, hey, when you see this virus, this is how you take it down quickly. So it gets a head start. And so the vaccine doesn't last in our system. The vaccine doesn't accumulate in our system. The vaccine isn't transmitted via placenta or breast milk to our kiddos. What the vaccine does is it just teaches your blood, it teaches your immune system how to have a strong response, and then it disappears. Your body takes it apart. Think of it like a Snapchat. It had its message and then it disappears. And then what's left is your normal immune system so that it's prepared to be able to take down the virus once it sees it. You already got that message and it goes away quickly thereafter.
Our next question is, Cordova has had 4 hospitalizations. Are the staff here as burned out, understaffed, and or overwhelmed in treating COVID patients as we read about in other parts of the state and country? Please discuss how COVID is affecting their workload and well-being.
Similar to other places, certainly our staff are resilient and here to support people, but it is a challenge to have to deal with all that comes along with COVID. When we hospitalize COVID patients, it means they're having to change in and out of PPE, which is an added task when you're moving between patients. Overall, I hear our staff here remaining very positive, and I have not had anybody turn in their resignation yet. So I think that Cordova is doing well.
Thank you, Hannah. And moving on to a question from the chat. Is it accurate to say that the greatest benefits of these vaccines are that they offer personal and individual protection from serious disease and potentially death, not necessarily preventing infection and transmission altogether? Would community transmission still be a possibility if Cordova had a 100% rate of vaccination?
Yeah, so it's a really good question. And before I jump to that one, big kudos to your health team. So congratulations, Dr. Sanderson team. It's fantastic. We need all the healthcare providers we have, and thanks to whoever asked that question because it has been hard for many healthcare workers. So I just appreciate that question. Regarding the second question, I think I would not fully agree with that statement for a couple different reasons. So first of all, vaccines do a couple different things. Again, if I got vaccinated, which I'm vaccinated, but I have that, basically, I got that tool, that Snapchat telling me how to take down the virus. If, Hannah coughs on me really quickly and we're not on Zoom and we're actually in person, and she gives me COVID-19 and it enters into my lungs, my body sees that virus, and it's kind of a race between my body and that virus. That virus is trying to take over my cells and replicate as quickly as possible. And my body is like, that's a foreign thing. I want to get rid of it. I'm going to try to get rid of it as quickly as possible. For most vaccinated people, they will completely get rid of that virus before they get enough in their upper airway to transmit it to another person, to become symptomatic, or to be able to get sick from it. And so vaccine does help to prevent transmission because it helps to take down that virus before you can replicate it enough to be able to spread it from person to person. But is it 100% perfect? Not at all. Some people, that virus gets a little bit more of a head start where their immune system isn't quite as strong, and that virus can then replicate, and it can become enough in the upper airway that then they can actually, cough, sneeze, talk, and spread it to another person. So we are seeing evidence that vaccinated individual people can spread it. It's just much more less likely than if everyone was vaccinated or if that individual was vaccinated overall. And then once you start to have enough in your upper airway, your body has still got that head start from the vaccine. And so it's more likely to take down the virus before it makes you really sick, resulting in you getting sicker, being hospitalized, or dying, or your immune system kind of going crazy, which is what seems to happen between day 7 and 10 for this virus, is people's immune system can kind of overreact and have so much inflammation as it's trying to fight this virus from numerous aspects and can make you quite sick. So yes, it does minimize hospitalizations, it minimizes death, but it helps to minimize transmission. It's not 100% perfect. So what happens if we're all 100% fully vaccinated and we're all hanging out together? Well, first of all, we can't all be fully vaccinated because we have our kids less than 12. So we have to still count them because they still are important, and they are important in the kind of this transmission chain overall. But say we live in a Zoom world that's actually a person that has no kids, and we have 100% vaccine. What would likely happen is that you could transmit COVID. You wouldn't get a lot of it, but people wouldn't really notice. Some people might get a little bit of a runny nose and sick, and some people might not feel well for a couple days, but most people would have mild symptoms. And if that's where we get with COVID, great. Go give your friend a big hug and maybe have a runny nose the next day. What we don't want is so many people becoming sick and overwhelming the hospital system as a whole. So I think that there's been a misnomer. I think it's really easy to understand the world in a dichotomous, a black and white view, like again with testing, either I'm positive or I'm negative, or there's COVID or there's not, or this is a risky situation or there's not. But the reality is that we are beautifully complex beings that live in this beautifully complex world. And we see a lot of different responses. So population-wise, it decreases transmission, decreases hospitalization, decreases death. But on an individual level, we still see breakthrough cases, we see breakthrough transmission, and we still see people being hospitalized and unfortunately dying from COVID-19, even if they're vaccinated. So it's not perfect, but it's darn good. I don't know, others?
Okay,
That was a great answer. I don't have anything to follow. Thanks.
Okay, next question. Please explain how many people are needed to treat one COVID patient in the hospital, both in an ICU and non-ICU setting, and how it compares to treating other ill and severely ill non-COVID patients in both ICU and not.
Yeah, no, Dr. Sanders, you want to start with your community and I can talk about from the state?
Yeah, so here at Cordova, we make things work. So in general, we have one doctor on and one emergency room nurse, and occasionally they'll have help with a CNA. So depending on the number of patients that we have, that's the number of staff that it takes to take care of them because we don't have more. Our staff does a very good job of taking care of people, but we do rely on the other hospitals in Anchorage to have capacity to take our patients when we need to send them. So here we don't have the luxury of worrying about kind of the staffing ratios that we look at other hospitals, but I imagine that Dr. Zink will touch on that.
Yeah, really like Dr. Sanders' point is like, it takes as many as we have sometimes. I think that's what we're experiencing in the hospitals right now. So the ratios for nursing have diminished over time, particularly with how stretched thin the nurses are. So in general, both in the emergency department as well as on the floor, it's usually about a 1-to-4 or 1-to-5 nursing ratio. So, one nurse will take care of kind of either 4 to 5 patients. And in the ICU, it's about a 1-to-2 ratio. Currently, they're all being stretched much thinner right now. And so in the ICUs, they're stretching to 1 to 3 to 4 patients in the ICU and a nurse to 5 to 8 patients in the ED in the med-surg, which is a lot more care. On top of it, it brings up what you mentioned. I'm just literally putting on PPE coming on and off. I was working in the emergency department this past weekend. This cute little demented lady was like, "You guys are all getting dressed up for a dance." And I looked and like all the nurses and I were all donning PPE together because we're all like going into separate rooms. And she thought we were all getting dressed up for some ball dance or something in our bright yellow gowns. But it made me pause and think about how much time we really do like have to put all this on and off when you're going in and out. The other thing in ICU care that can be really labor intensive is what's called proning. And so when you put someone on their stomach, it helps to open up their lungs and so you can oxygenate them better. Proning is not easy. It's easy when you're in your bed by yourself and you're not attached to a ton of monitors, a ventilator, and a bunch of IVs. But when you're attached to all those things and you're trying to roll someone, you have to be really careful that those lines don't get moved and the tubes don't get pulled and the medications keep running and they don't wake up, and it can be very tricky. And when people are super sick, they can actually code just with that movement. Just a little bit of movement can cause their heart to stop. So it usually takes at least 4 people to move one COVID patient. And so in the ICUs, they're spending usually 2 hours twice a shift going through and proning patients. And so all the nurses gown up and they just go room to room to room, proning and turning patients from side to side, which takes hours of their day away from all the other nursing care. But it's a highly coordinated dance that they also have to do to make sure that they're caring for those patients. So it's all of those additional burdens that does make it more challenging. I think the other thing that's sometimes a misnomer, a heart attack might be in the hospital 2 days, 3 days. It's really rare for a heart attack to be there a week, a month, 2 months, but it's really common for these younger COVID patients to be there, 6 weeks to 2 months timeframe. And so one hospitalization can be months of proning patients, of moving back and forth and trying to keep them alive. So the length of stay is much longer with many COVID patients, and it's just physically exhausting. And the other thing that's really been challenging is caregivers aren't at the bedside like they were before. We want family in there. Like family is who helps to care for us in so many ways. It also helps to decrease the burden on nurses. When someone's confused or they're demented or they're, lonely, having a family member sitting by their side makes all the difference in the world. But when you're trying to reduce the overall COVID burden, we aren't having as much family and friends in the room as well. So you're holding up the iPad so that they can, say goodbye to their 10-year-old daughter. You're having these just heartbreaking, heart-wrenching conversations. And so it's not only the physical burden that's happening right now in the hospitals, it's just the sheer exhaustion and mental burden of seeing healthy people dying from what's increasingly a preventable disease again and again, and feeling like there aren't a lot of tools and just feeling exhausted. So anyway, it's probably more than you wanted to know, but it's both physically and mentally a lot for our medical professionals right now.
I'll add one more thing to that, Anne. Thank you. It's incredible to me to think of our ICUs with a nurse taking care of 3 or 4 patients. I've worked in ICUs and had the experience of feeling like I needed a single nurse to be taking care of one sick, intubated, ventilated patient. So I think the reality of that is a really big deal that we as medical providers recognize, but sometimes our community doesn't get to see.
Right, next question. Will we be able to get an electronic version of our COVID vaccination records anytime soon? And what is the outlook for vaccine authorization for children 5 to 11?
So I'll take the first part and then I can turn it over to Coleman for the second part. I really hope that you can be able to pull your own records at some time in the future. So sorry about the cyber attack in the middle of the pandemic. That's not been fun. But that has definitely limited our ability to move some of the IT things. So we're hoping that you'll be able to look up your own immunization record at some time soon. We are putting together, it should hopefully go live next week, a much more manual process where you can fill out a form at the state to be able to request and show your ID to get your own immunization record, because a lot of people have lost cards since this pandemic started. So we want to make sure that's easier. In the meantime, we have been recommending people talk to their provider. So I don't know, Dr. Sanders, what you tell local residents, but that's what we're doing in the state.
If you call your PCP here, we can get you a PDF file of it, of your vaccine record emailed to you.
That's why you live in Cordova, because that doesn't happen everywhere. I don't know, Coleman, what else would you add about the childhood immunizations?
Yeah, I will say this was something that was in the mix for a while before COVID started. You know, this being able to access your own vaccine records, because there's a lot of reasons why you need them. I just needed them for my kids to go back to school. So for kids under 12, a few things that we know. So Pfizer has completed enrollment in their trials. What that means is they're not taking any more people. They've reached enough to where they're done and they're studying them and they're going over the data. That's good news because now we really have like a set timeline. Before that happened, we were like always a rolling 4 months out, and it kept going and it kept going. Now we're on a much more real, 4 months out. I'm still guessing like November-ish. I'm very hopeful that we should have approval, if all the data works out. Like, we don't even know that for sure yet because none of us have seen it. We don't have a reason to believe that it doesn't, but, so let's just say that, there's not some reason why it doesn't get approved. I expect the FDA to meet and then the ACIP to meet really hopefully before the first of the year. I'm guessing kind of November at the soonest. For kids under that, we do know that Pfizer and Moderna are studying in 6 months and up. Those trials are still enrolling last I checked last week. And then we'll kind of be in the same scenario. Once they meet enrollment, then we'll get a whole lot closer to this real, 4 month out time frame.
All right, we have a question from Miss Ann Schaefer.
Hi, yeah, thank you. My question is going back to transmission. So as you said, we know that vaccinated people with breakthrough cases can transmit the virus. But I was reading recently that vaccinated folks with these breakthrough infections have potentially a similar viral load as unvaccinated folks, but perhaps the period in which they're contagious or transmitting is shorter, so they're less likely to spread as widely. Is that the case? And also, does this pertain to symptomatic and asymptomatic breakthrough cases in the same way?
Yeah, so great questions. I would break that down into kind of 3 parts. So a vaccinated individual is less likely to get COVID in general, any sort of infectious case, and to be a vaccine breakthrough than an unvaccinated individual. So again, if we look at the efficacy of these vaccines, if you were to take 100 people who are all completely susceptible to the virus and spray everyone with COVID-19 through their vents, we would expect in a group that was completely susceptible to it that you would have 100 of those people would get infected. If they had all been protected with the vaccine and currently with the Delta, we would expect about 85 of them to not develop symptomatic infection at all. And even when you tested them, to not be able to test positive. But that 15% that are symptomatic and are kind of testing positive in that sense, their CT values, their infection looks similar to the unvaccinated group. So you get rid of about 80 to 85% of them kind of off the start. There may be a degree of asymptomatic in there, and that part we're still trying to figure out, but you're going to get rid of a bunch of people who are just not going to produce enough virus to even test positive. And then of that 15% that did test positive, as you mentioned, they would be more similar to an unvaccinated individual in kind of their CT thresholds and their value. But also, as you mentioned, they have a shorter window. So they clear the virus more quickly. So they are not infectious for such a long time. So again, the vaccine helps to prevent them getting the virus enough to actually develop in their airway to actually be a breakthrough case. If they do develop it in a breakthrough case, it is similar to someone who's unvaccinated in the viral loads, but that time frame is shorter, and so that also reduces their transmission. Does that answer your question, Anne?
Yeah, thank you.
Okay, are there treatments that can be taken as soon as one is symptomatic to minimize possible effects? So one doesn't have to wait until one has difficulty breathing to get treated. The hope being that an early treatment would prevent the infection progressing to the point of needing a bed in the ICU. Last year, Dr. Fauci said he takes vitamin D to boost his immune system. Aside from that and the vaccine, are there other preventative measures one can take to fight off and or prevent a COVID infection?
Yeah, it's a great question. I'm going to hand it over to Coleman, who's our trusted pharmacist in this space. I would just state that overall, taking care of your health is incredibly important. So there's one thing to take away from it. Yes, exercising, eating well, making sure you're not vitamin deficient. Many Alaskans are vitamin D deficient. Eating a good fish diet actually helps with that. Actually, we get a lot of our vitamin D from salmon. So congratulations, Cordova, for getting your vitamin D levels up in that sense. But then once you get sicker, Coleman, tell us what we do.
Yeah, so the best thing we can do to prevent is get vaccinated and be healthy. So, if you have chronic diseases, keep them controlled. Controlling your blood pressure, controlling your diabetes, controlling your asthma, any chronic diseases, controls better. Also taking care of our overall well-being, get enough sleep, maintaining a healthy weight, eating a healthy diet, a diet diverse, rich in vitamins, nutrients, things like that. In terms of medications, viruses are hard to treat. I've been saying this for a while, and it's true. I come from an infectious disease background for a lot of my career, and in general, we don't have good medication treatments for viruses. A couple of them we do, but for the overall general exception, what we really kind of our mantra is, mitigation, not medication. So unfortunately, treatment options aren't really well. We do have this class of drugs called monoclonal antibodies, though. We actually use them for RSV in NICU kids as well. What it is it's an infusion. It can either be given via IV or subcutaneous injection. And if you are infected early and high risk, it can be beneficial, up to about 70% beneficial in reducing your risk for severe infection. Vaccine is still better, but this is kind of like a safety net drug, and it is available. The key with that, though, is you really have to give it early. So if you have any possible symptoms, it could be COVID, get tested. If you test positive, talk to a healthcare provider, because these are prescription medications, and they're ones that aren't necessarily easy to deliver a lot of times. But those are effective, in preventing someone's risk. By the time you get to the ER, with Dr. Zink or another ER physician or Dr. Sanders, it's too late. They don't work anymore. So really that early treatment is the key when we talk about this class of drugs.
And then I would also say that we've gotten much better at treatment options once you're in the hospital as well. So, when we were first learning so much about COVID, 18 months ago, there were a lot of protocols and there were a lot of different things that were tried, but we are getting a lot more data and evidence on what works and what doesn't work in general. So if you get sick enough that you require hospitalization, please don't use welding oxygen and stay at home. That only makes your lungs sicker. We've been seeing more of that, honestly, within the state. We are here to care for you and not to judge. And so vaccinated, unvaccinated, whatever you took thinking it was going to be helpful and it may not be helpful and you're getting sicker. I can't tell you how many patients I've been seeing in the emergency department using ivermectin, large dose steroids, a lot of antibiotics, and welding oxygen at home and getting sicker and sicker and sicker and coming in just miserably ill. Because they are hoping to have a treatment. We want a treatment. We want you to be better. And if I had a magic pill that would make this all go away, I promise I would distribute it widely, but we don't. And it's just a series of things and a lot of hard work from individuals keeping their own immune system healthy and trying to minimize the virus itself. Once you're in the hospital, once Coleman maybe tried the monoclonals and you're there and now you're hypoxic with us, so there are some antivirals like remdesivir that can make a difference to some degree. Steroids can be helpful later, and then there's some additional immune modulators. We also see a lot of blood clots associated with COVID, and so we see people getting blood clots in their lungs. I've seen 20-year-olds with no heart history who have developed heart attacks afterwards, as well as big pulmonary embolisms, clots in their lungs. After COVID-19. And so there may be a role, particularly in some patients, in like anticoagulation to minimize that. So Dr. Sanders, anything else you'd add from a treatment perspective?
No, I think you covered it.
All right, perfect. We have time for one more question this evening. We're going to go to Miss Sarah Parker.
Hey, thanks. I heard an interview on NPR last week with the U.S. Surgeon General Vivek Murthy, where the Surgeon General indicated that eradication of COVID wasn't necessarily the goal, and he suggested that COVID will eventually be endemic. What does that mean? And looking ahead with COVID, at what point would we transition from pandemic to endemic?
Yes, it's a really great question. So endemic versus pandemic really depends on if you're seeing flare-ups in a certain region versus the whole world as a whole. So pan means the whole world and is being impacted versus an endemic is just going to have local regions where you're going to have flares. So I think of like measles and mumps as diseases that are endemic. So you'll have regions where it will flare. Even polio, as mentioned, I don't worry about my kids going to swimming pools in the summer and worry about them getting polio like we may have, in the 1940s. But we do worry about COVID right now, and in other regions in the country, in the world, polio is more of a threat. So it really depends on kind of the overall worldwide burden of this disease. No pandemic lasts forever. No epi curve goes up forever. This too will come down, and this too will get better. The question is how many people will we lose in that journey and in that process? I oftentimes think that we are all in the sea together. We are just in different boats. And we can bolster our boats and our life jackets by being vaccinated and by being tested and getting monoclonals early. Again, it's just those safety precautions that we have, but we're in a rough sea right now, and those seas will calm down. This will become less of a burden. How long that will take is hard to say, but it's been helpful for me to review the literature from, I just finished a book on polio, the plague, the 1918 pandemic. These things have happened for centuries and will continue to happen. They're rough, they're bumpy. We lose a lot of people along the way. But when we collectively work together and realize that the virus is the enemy and not each other, we're able to perform much better. So I agree with him. This will eventually become more endemic instead of pandemic. But how many Alaskans we lose is the question. I don't know, others?
I think you covered it really well. And I think you made this point earlier, but our goal right now is to not overwhelm our hospital capacity. And so that is part of this big push to continue these mitigation strategies. Is our hospital capacity is currently overwhelmed, and we're trying to prevent it from collapsing. And so I appreciate the community's resilience, and I very much appreciate Dr. Zink, your resilience, and Coleman of guiding Alaska through this. You have done an excellent job. It's been a long haul for all of us, so thank you. Thanks for joining us tonight also.
Well, it's a huge honor to join you guys, and I agree, Alaskans are amazingly resilient. We find ways to work together and to support each other, and this is yet another challenge, and we are all done with it. We all wish it was not the case, but just as Dr. Sanders mentioned, we don't want someone who has a heart attack not be able to get the cardiac care that they need, or that trauma, or whatever that looks like, or someone vaccinated or unvaccinated who has COVID-19. We want to make sure that we are here for you. We took an oath to do no harm and to serve whenever we were needed. And I think that's what's been so hard for medical professionals, is not be able to have the tools to serve when they want to serve. So that's why we're asking for you all to help us with that, so that we can be here for you if you need us at that time. So I appreciate the resiliency of the Cordova community and being able to stand into this space.
All right, thank you so much, Dr. Zink, Dr. Sanders, and Dr. Cuttins. If anyone has questions, they can go ahead and email those to the cordovaprepared@yahoo.com email address if there's any remaining inquiries, and we'll make sure to get those answered for you. And for this evening, thank you and good night, everyone.
Thank you.
Recording stopped.
All right, that went well.